Okay, so it's just 1:30. So thank you for joining. If you have just joined, any questions that you do have, please pop them in the chat and we will have a certain amount of time for a Q&A. If you can just pop yourselves onto mute, that would be really helpful, just so we don't pick up on any background noise. The session is going to be recorded, and we will be sharing slides and the recording after the session as well. So thank you for joining this remote monitoring in general practice masterclass. It's part of the masterclass series that Redmore Health and Health Innovation North East North Cumbria are running in partnership. And I'm just going to pass over to Kay Bryden from Next, who's going to take you through the rest of the session.
Good afternoon, everyone. Thanks, Anna. This afternoon to talk about remote monitoring in general practice. For those of you that don't know me, I'm Kay Bryden. I'm a business change and benefits lead for Next. I've been working with practices across North East and North Cumbria for the last couple of years. At the moment, supporting primary care access recovery plan amongst other projects, and this remote monitoring project being one of them. I'm quite passionate about this project because I spent several years working as a receptionist in a busy GP practice, so it's something quite close to my heart, and I do appreciate the pressures and demand of the practices and staff are under at the moment, but also the importance of patient choice. So I think this has a really good, there's a lot of valuable learnings come from this programme of work that hopefully we can share with you in your practices. So remote monitoring, so why are we doing it? So it's come to mind that remote monitoring can be a variety of things to different people. So people are thinking it might be virtual wards, support apps, devices. For this particular stream and this particular programme, we've kind of looked at actually how we streamline processes with the age of digital tools and technology. So it might be those apps, but actually those software you've got available to you at the moment. So this will help support the delivery of those primary care access recovery plan, but it's also looking at how we design those clinically safe pathways and try and create that process documentation to support practices who want to look at changing their internal processes and also to start empowering their patients to better support their own health needs. So why did this programme come about? So there was a digital maturity assessment sent out to practices in Newcastle and Gateshead, and interestingly, 87% of the responses, so 27 practices out of 31, all expressed a desire to increase the usage of their remote monitoring within their practice. We've actually recently had some very similar interest in support from practices in North Tyneside and across North East North Cumbria. So there is a real interest in desire in using remote monitoring to look at supporting capacity at the moment. So at the start of this programme of work, there are lots of questions that we started to ask ourselves with regards to the project. How best could we as a team support it? How could we empower patients, and how can we deal with those current issues? How can we make patient and staff experience more rewarding? And actually, there is a big recognition of the fact that retention of staff within primary care at the moment is really, really difficult. So how do we future-proof our services for years to come whilst recognising the need for patient choice? So we decided as a team that rather than adding extra layers, we'd kind of just look at using what we currently have. So using the software like the likes of AccuRx, eConsult, iAtro, anything that was out there that practices already have, and just using those tools that are already there rather than adding an extra layer in and something else for somewhere for practice staff to have to look. So it was just an aim of working better, working smarter and not harder, but it was also vital to recognise that it needed to be clinically safe. So with this in mind, we added a GP, Dr. Becky Haynes, to the team so that any pathways that were designed with the practices also had that independent GP clinical assessment to verify that they were clinically safe. So from there, we moved on, and the plan of action was to work with 5 practices who were part of the initial pilot project. We met with all the practices, en masse and held an innovation design services session, which was hosted by the health innovation team. So this session asked the practices to just really stop and think about what they wanted, what their ideal scenarios would be, kind of what was holding them back, what was driving them on. And there was a load of common themes that come through from that, but there was a real desire for change. We also discussed on that day sort of any particular specific condition areas that they would like to focus on. And then we asked the practices to map that patient journey of the conditions that they've chosen. And look at actually what were they doing now and what steps in that process could potentially be replaced with digital tools and access. Not necessarily a case of getting rid of every step in the process, but were there elements where we can go, actually, why have we got a patient coming in there? We don't need them to. Sort of feedback on that session has been that practices have really found the ability to step back and reflect on their processes, question why they're doing it, and actually, more valuably than anything, thinking like the patient has just been like a light bulb moment for them. It's given them that opportunity to really think about what they were doing, and it's kind of prompted a lot of questions. You know, a lot of sort of even clinical staff are saying, why have we got these patients coming in? It's you know, they're having to contact us 7 times. There has to be a better way. So it was really interesting to sit back and watch that thought process and then see the practices kind of run off and explore that further. So just as a kind of quick example of the kind of things that came up. So from the sessions, the pathways that we kind of took away were contraceptive reviews, UTIs, hypertension, diabetes, new patient health checks, and HRT was a really common one amongst others. And there's just a quick glance of kind of what the practice was doing pre sort of change and then post change. So, you know, for example, this UTI pathway, every patient who was coming in who wasn't suitable for pharmacy first was being seen by a GP. Now there's a lot of data gathering going on outside of that. So it might be that we can't omit completely the need for that GP appointment or that clinical input, but actually we can alleviate that necessary need for a 15-minute appointment for a patient to have to come in they maybe don't need to. Similarly, a contraceptive, and we did have a couple of contraceptive different pathways, but again, every patient was coming in, they were getting monthly prescriptions, having a 15-minute face-to-face appointment. So it was like, how can we get that blood pressure and weight? How can we date together remotely and separately to stop that unnecessary need maybe for that patient having to come in? Again, it's really all about that choice. So with that, I'm going to pass it over to Chris Drummond. He's going to talk to you about his experience of the pathway. He's a team lead in Teams Medical Practice, and it's his journey at the end of the day, not mine. So he's going to speak to you about his experience of the process.
Cheers, thank you, Kay. Good afternoon, all. My name's Chris Drummond, and I'm an IT and QAF lead at the Teams Medical Practice in Gateshead. And as Kay said, I attended the first remote discovery day nearly a year ago now. Times flew, but you wouldn't have thought it was a year. But we attended a session in Newcastle. I attended with a GP from our surgery. And as Kay said, we sat and looked at a few pathways on how it looked from a patient perspective. And could we make it easier for a patient and cut down those unnecessary contacts? So as Kay's mentioned previously, the UTI pathway is a pathway we've had in the teams. We came away from the discovery day and we sat and designed with the clinicians and with Dr. Becky Haynes as well, a safe pathway. So the patients didn't need that 15-minute face-to-face appointment. When the phones ring at 8 o'clock in the morning, the appointments would quickly fill up. And we would see common 2 or 3 UTIs a day. So we designed a pathway where they didn't have to have that initial 15-minute appointment. The old pathway for us was patient rang up, described symptoms of a UTI. If they weren't suitable for pharmacy first, they were just popped in with a GP. They would come down and the GP would handle that. What our new pathway has done is it's took all the admin and a lot of the legwork away from the GP. So now a patient we send just a flurry out to a patient. The patient will answer the questions on the symptoms they're having and what they're feeling. They would drop us a urine sample in, which the nurse will then handle. It takes that away from a GP. And then the GP on that pathway has the input at the right time. When he's got all of the facts in front of him, when he's got a DIP result and he's got the patient's answers from a flurry. This opened up a few appointments a day for the GP to then see patients that had other complex needs. So it wasn't completely removing it from a general practitioner. It just made the patient feel more involved and knew what was going on, and they knew that they would be contacted, and it was a quick 5-minute phone call instead of a 15-minute appointment. We also did the contraception pathway, our old pathway in the surgery again, as you've just seen on the screens previously, was patients would be booked in for a 15-minute slot with a nurse on a certain day at a certain time. This would pin the patient into that appointment. They had no flexibility. They had to come in for that. But again, working with clinical staff and Dr. Haynes, we've designed a pathway where we can do all of the information gathering without the need of the patient actually having a nurse appointment. The patient can use remote kiosks in surgery to gather the information needed, such as height, weight, blood pressure. They also use community pharmacies to pop into the local pharmacies to get the information for the questions we ask. And then instead of, like you say, them having a month review every month, our pharmacy technicians now pick this up with all this information they've got from the patient with a 10-minute phone call and then prescribe for a further year. So again, it frees the nursing team up to focus on SOQUAF reviews, in other things such as dressings and injections. Coming away from the discovery day, it was quite nice to see a change in the surgery. We had to implement this not only on a clinical perspective, but also on an admin perspective. This would only work if we have both sets of teams working together. We had to drive it in the admin room as well as reinforcing it to the doctors. And one of the biggest challenges we faced in surgery was getting the admin team on board. We had a lot of staff who are long in the tooth, who have been here a long time, who have comments such as, "We've seen this before, this will not work, this will not happen." Again, we've took them on a journey and we've just ran with it. We started this in July last year. We put it into practice at the back end of October in 2023. And as of last month, we're approaching nearly 100 hours of clinical time that we've not saved that a doctor can say 100 hours of patients, but we've cut it down so the patients made it a lot easier for us to have an input with them. The key question is, why should you do remote monitoring? Well, it makes the journey easier for the patient. We had a patient who was seen on a UTI pathway through the pharmacy first from our office in Newcastle. She didn't have to leave work. She went downstairs to our local Superdrug and was dealt with. These pathways have reinforced the pharmacy first. It's also reduced the amount of unnecessary contacts the patients had with her. So instead of bringing them down to see a doctor for a UTI and they can't do a water sample there and then because they're nervous or they don't want to, so that they would normally go away and come back with a sample, then go away, then come back and see the doctor for the results. It just reduces all that everything is with the doctor when he needs to call a patient. We also set this up with no investment. We've made no purchases. We've not got any new technology. It's simply all being done with EMIS, an EMIS F12 protocol, and an Accurix flurry. There's nothing that we've had to pay for. So you've got the tools there. You just need to have a sit back and think of, does the patient need to see a clinician at X, Y, and Z? Or if they do, can we do it remotely? Can we do it by text, email, whatever? And again, excuse me, like I say, on contraception, we've freed a lot of nursing time up to do checks, and it also frees the GP time up. They don't have to prescribe either. We've got a pharmacy tech who happily issue the medication. And now, because we've done this pathway and because I've been on this journey with the team, every time we look at a new pathway or we're looking at anything in the team meeting in surgery, remote monitoring's at the forefront of what we do. We are now thinking for like the HRT reviews. There's a lot of patient contact. How do we cut that down? How do we get the patient involved? How do we get information to the patient to let them make a decision and get the clinician to the patient at the right time? So it's definitely a journey I would recommend going on. It doesn't have to be UTIs or contraception. It can be absolutely anything. And you'll hear from now Jeannie Henderson, who'll talk you through what experience she's had with the journey. Thanks.
You're on mute, Jeannie.
Can you hear me now? Yes. So
yes.
I'm going to be reflecting a lot of what Chris says. We had two pathways that we initiated, and one of them was the contraception review, which was probably the most successful that we've had. At the time that I approached our GP, sorry, my name's Jeannie Henderson, I'm an advanced care practitioner from the Village Surgery at Cramlington. So when we initially approached our GPs about introducing an e-consultation process for contraceptive reviews, they were very sceptical. They were already quite sceptical about e-consultations because they felt that there was a lot of disadvantage around patients who could fill in e-consultations compared to those who can't, like the elderly. However, we've since put a good process in place, which means that they're triaged. So those people who don't necessarily need urgent appointments, who fill in consultation, haven't got an advantage to those who are trying to call the surgery. So that's really helped. So anyway, we decided to introduce the contraceptive review for two reasons. First of all, we have nurse and staff shortages as far as clinic appointments. One, because a lot of the staff were doing apprentice top-ups, so they were on placement. And the other thing was that we were getting lots of requests for pills where the patient's pill review was out of date. So they were ending up with monthly prescriptions over and over again. So we knew it was an issue. So the first thing I did was gain the support of an IT support from the practice, because we knew it needed a two-pronged approach, clinical and IT. So Cody helped me a lot, who's great with the system one. We did initial audit and found that I think we had around 450 patients that were prescribed the contraceptive pill in the last 12 months, and 107 of them, their pill review was out of date, which was a quarter, quite a lot. Seems a huge amount really, or they didn't have a latest blood pressure or weight. So the first thing we did, just to trial how it would go, is we set up an Accurix text and sent these 107 people a text to say that the pill review was out of date, and with a link to the e-consultation pill review, with also information on how they can obtain an up-to-date blood pressure reading that was either through Boots or to book an appointment with one of our healthcare assistants for 5 minutes. So instead of a 15-minute appointment, they only needed a 5-minute appointment. When we audited how many appointments we were using a month on pill reviews, it was about 25 nurse appointments a month and about 9 GP appointments. So we know we were going to probably save a lot of clinical time through this. We got a great response. Initially, it was a few teething problems in respect of people filling the e-consultation without the blood pressure or partially filling it in. But we overcome that. To set the process up, we did do a clinical governance. We took it to our clinical management team to make sure that it was safe, effective. It followed UK MEC guidelines. The process is that our med tech, similar to Chris's, will receive the e-consultation. She will code the e-consultation with regards to the pill review. Any red flags she'll address to the GP. So if someone's overweight for a contraceptive pill, or if their blood pressure's out of range, or if they've had any changes, like if they've developed migraines or abnormal bleeding, that would go to a GP for review. Otherwise, if there was no red flag, she would code it, make sure they have the blood pressure and weight, and then issue the pill, which worked really well. So the teething problems did improve over a couple of months when the patients got used to the process. They were getting blood pressure checked before they were filling the consultation. That worked really well. So it's still ongoing. the audit has showed that we've probably saved not 25 appointments a month, but probably 20 nurse appointments, because we still have patients that are booking in for some reason they want a face-to-face appointment. I think we'll never change that. There's some people that just prefer face-to-face appointments. We've also introduced smart inbox with the help of Care, which means that that they're already coded, so it's less work for the med tech to do. So it's worked really well, and I would recommend it to anyone because it has saved us a lot of clinical time. Patients prefer it. It's more convenient for them. It's simpler for them. It's reduced waste, because instead of multiple 1 month appointments, which is also a financial implication for the NHS, it's just 6 monthly or yearly appointment prescriptions depending on what's needed. So there has been some waste reduced from the system. As far as reducing risks, we've identified patients whose pill review was out of date, 2 patients that received blood pressures through actually boots, because we get a little report. They had hypertension that had been undiagnosed, so that's been a good clinical outcome for that. We've been able to manage their hypertension before prescribing the pill or ongoing. So it's been quite a good experience. The GPs like it. In fact, now they're warming very much to e-consultation. It's now part of our process. Our on-call GP's role is to manage all the e-consultations and triage them during the day. So it's now a big part of our work stream. The other pathway we had was for a patient registration. That's still in the teething form, because we're very much system 1. We get a lot of new patient documentation through with multiple codes on, so we've still got a lot of clinical time going through and cleaning up all those codes before the registration process is complete. But it has helped the initial it's improved patient experience, because we were doing all new patient checks before. When we through the initial patient registration form, we will just code them, see them at the next annual review, and not everyone requires a new patient check. I don't know why that was happening, but that was a process I've had in this practice for a lot of years, that every patient who was registered underwent a new patient check. And now it's only those who it's age related or have got a long-term condition. So we've reduced a lot of waste in the system there. So it's been a positive experience for our practice, and I would highly recommend it. I'm happy to answer any questions.
Thank you, Jeannie. Has anybody, actually it's probably quite a good time to stop for questions. Is there any questions from anyone at the moment?
There hasn't been any questions in the chat, but if anyone wants to come off mute and just ask a question, that's fine as well. Doesn't look like anything's coming through now. Back to you, Kay.
Thanks, Anna. Thanks, Jeannie, and thanks, Chris. So obviously 2 really positive sort of experiences there from both the practices who've seen quite a bit of success from their pathways. I think I would absolutely just stress what they've both said in regards to kind of, it's important to have that baseline data as well. Have an idea of what you've currently got coming through your doors prior to sort of taking on any of these pathways, just so you can actually see on paper kind of those changes that are being made and actually see that change in the process. But equally, I think right through this process, it's really important, if it is something that you're going to consider as a practice going forward, to have that 2-pronged approach. It has to have that clinical and admin drive in equal proportions. It's difficult to get off the ground one without the other, so it is really, really important to kind of keep that in mind. If it is something that you're going to think about, is to just ensure that you have both that clinical and administrative stream to it. Otherwise it can be a lot more difficult to get up and off the ground, and we have seen that as part of the pilot programme. I was just going to move on to sort of project documentation, benefits and lessons learned. So for part of this, what we've tried to do to sort of spread and adopt the remote monitoring across the patch is, in regards to all of the pathways, we've produced some project documentation. So we have SOPs, we have flow charts, we've tried to incorporate examples of the Florey questions or e-consult questions. examples of text messages. So there is as much information in there for practices who are thinking about maybe sort of implementing one of these pathways. You know, there might be some lessons learned in there, and a little bit of narrative about sort of problems or why the practices have chosen to do it. I've popped some examples in here. So the SOPs, you know, will be your 1, 2, 3 guide. You kind of talk you through the process. It'll just identify any of those missing gaps. Really useful if it is something you want to implement, because you can kind of use that as a guide to actually which bit of the process do we need to tweak to suit us as a practice. You know, equally for those who are sort of learn a little bit more visually, we've reflected everything into a flow chart. Chris touched on the fact that actually they use this in their F12 functionality within their clinical system as a prompt for their staff. So it got all of their staff thinking and working in the same way. And it was just really useful to have that as a tool at a glance for them to follow if there was any questions. You can find all of the support and documentation on the website. The website is just gone live, and I'll run you through it, but I'm going to have to stop sharing. So if you give us 2 seconds while I just flip to the online, because unfortunately it won't let us do it in the one screen. So just bear with us 2 seconds, and I'll just stay. Anna, can you see that?
I can see it.
Perfect,
Yeah,
brilliant, thank you. That's
Mhm.
great, thank you. So it'll take you, that link that's in the presentation will take you straight to this landing page. If I scroll really quickly, it's because there are some videos on here, and unfortunately it's my face and I don't really want to have to see myself looking back. So I'm going to scroll really quickly past this bit. And here you'll find all of the resources. So for example, underneath the UTI, you can just click on the download UTI resources. Like I say, there's a little video there for each pathway, but it'll take you to the standard operating procedure. Like I say, the step-by-step guide of what the process is. Underneath that, you'll find that you have the flow chart, should you want to use and adopt that. And again, the examples of the text messages and the flurries. We maybe don't have those for every pathway. Obviously, we've shared with you what we have access to, but we've tried to give you as much information in there as possible, just so that if you want to use it, it's there and you can. So, sorry, I'll just flick back again. And I'll just talk you through some benefits. So, I mean, Chris and Jeannie have both touched on the fact that, you know, we've seen those time-saving benefits. Yeah.
Sorry to interrupt that.
That's
it's
right.
Just flicked that back
Yeah,
now. Sorry, it was on the first one. Thank you.
It was stuck. Yeah, sorry, it's on a bit of a go slow. So yeah, it's the benefits. So like they've both said, we have seen those sort of time-saving benefits in regards to appointments. That has been backed up by we had some evaluation done by Sunderland Uni, and all of the practices as part of the pilot project had to submit their baseline appointment data to the uni, so we could actually verify those time savings. Like they've both said, so Jeannie touched on, potentially it wouldn't quite be 25, but on average 25 appointments being saved per month from the contraceptive pill check, just using the e-consult instead of having a patient come in for an appointment. Similarly with the new patient registrations, we could be looking at 20 appointments being saved. BP at Home, that was a practice who used the BP at Home Health Call app, and just through refining their pathway, they've exceeded their monthly targets now by 100 patients. They are, I think, one of the practices across the area who are using this app really, really well. And I know from a lot of the other practices on the pilot program are really looking to try and adopt that, because at the moment it was available for them to be able to pick that up. So that was a really successful pilot as well. And like Chris said, you know, potentially 35 appointments, GP appointments per month, with hundreds of GP hours potentially being saved, not necessarily to see more patients, but just to kind of free up that admin time and actually just be able to spend that more valuable time with patients. But similarly, and Jeannie touched on this, we've also seen that improvement in clinical safety, not only with sort of the patients they had picked up, but we had a Savile practice who implemented a hypertension pathway. They didn't have a process for some of their hypertension recalls, and actually realised that there was a large cohort of patients who just weren't clinically getting picked up. So, you know, they made that improvement in their clinical safety by the fact that they implemented a pathway that wasn't already there. We've seen improved patient access and choice just for the fact that actually not every patient wants to come into practice. Increased staff satisfaction and experience. Chris has said a lot of his staff now just wouldn't go back to the old way of working because it was just far more stressful for them. And obviously those improved practice efficiencies. So I think across the board, there are improvements to be made by just those simple process changes sometimes. Key learning from the project is that I think primarily it's really important to just have that thinking time, which I know is difficult, but hopefully for those other practices who maybe want to look at these kind of areas of improvement, a lot of that thinking and mapping and teething problems is kind of already being done for you. That not to say you wouldn't have that, but actually there is a plan there, there is a process there. If you don't know where to start, here's a starter for 10 and see how it works for you. The technology and software already exists. You know, Jeannie touched on the fact that actually they weren't really using eConsult, but now they are and they're using it much better. So it's sometimes just kind of adapting what we have and working with it smarter than we were before. And there are ways to shorten or avoid appointments. You know, do you have to see every patient? But I think key to this is patients can be really supportive, but it's important to let them recognise they have a choice. Again, Judy said not every patient wants to come in, and I just think it's really important to keep that in mind if you're changing a process, to not make it be that is the only option. People need to have a backup option if they aren't comfortable being seen remotely. As part of this, we did some work with Involve North East to carry out actually some patient surveys post the process changes, just to kind of get that patient feedback and see how they'd found it. The majority of survey responses about the new pathways were really, really positive. As everything, you know, you're always going to get some patients who have a negative experience, and no matter what you do, you won't ever negate that. But I think, again, the key sort of feedback from this was it's really important to have that choice. You know, for some patients, they didn't realise that they were taking part in a new process. That's common in general practice. Quite often we'll maybe tweak something we do internally and they never have a clue. But until when you then go and ask them for their feedback about it, they'll kind of comment that they didn't know about it. So I think it's just for us that learning of, you maybe need to have some clarity. It's maybe worthwhile putting something on your website to say, we're changing our process, we're doing this, that, and the other, just so that actually it gives them that information. You know, knowledge is power, or that's the way that I look at it anyway. And actually, interestingly, sometimes when patients were saying, oh no, I've been told we can do this, we can do it remotely, not maybe all staff were aware of it. So it's really important, if you are implementing a new process, to ensure you do that training with your staff and make sure that actually all the staff are aware of the process, because it then does make it complicated for patients if they're getting those mixed messages. So that was kind of some of the really more important sort of feedback we picked up on from the patient engagement. And again, these were just a few of the patients' comments that had came back. Like I say, on the whole, it was a really, really positive experience for the majority of patients. Screen's gone a little bit weird. I don't know what's happened there. Apologies. So we did, the Sunderland Uni did an evaluation report. That again is available on the website. I'm not going to go too much into detail because it is quite a long read. But the main points were basically that the pilot programme had been a success. You know, that it does underscore that there's real potential for remote monitoring to enhance patient care and address the challenges that we have sort of in primary care and increase that capacity. You know, it is kind of encouraging that self-management, that empowerment of patients, and it is all about giving patient choice. So I think I think on the whole, all of the learning it's been a really quite positive project to work on, and there is a lot of valuable information, and that information is there for now to you if you decide that you want to proceed and go ahead and kind of look at actually your internal processes yourself. We've factored all of that into our approach going forward, but I'll not touch on that too much. I'll just ask before I move on to Rachel, are there any questions? Does anybody have anything on maybe any of that other information?
Please either pop them in the chat or raise your hand.
No, nothing?
No, there's nothing coming through.
Oh, have a hand.
Matthew, you've got your hand up.
Oh yeah, it's probably just for Chris really. Would he be happy for me to kind of visit the practice and just sit through and just see what you've done? I mean, I'm more than happy to have kind of a crib sheet or anything like that. We operate on EMIS Web as well, so I don't know whether that'd be easier, but just stuff like that. I'd need to just see what our protocols are in our practice.
If you drop us an email, if you want to pop down, I'll find an hour where I'm free. Yeah, absolutely.
Yeah, thank you.
Yeah, and if you have any other questions, if there's anything off the back of that, please just reach out and we'll chat with you and see what support's there for you. So with that in mind, I'll pass you on to Rachel Forbister. She's the programme manager for this piece of work, and she's just going to discuss the next steps with you.
Thank you so much, Kay. That was fantastic. I'm really delighted that we've been able to put this session on today. There's been a lot of hard work over the last 12 months. As Chris has touched on, we ran a discovery day, and as a result of that, we've done some brilliant things. And for me, it was great to be able to help practices to share and learn, because it comes together as an action learning set to see how you do something different. And then Matthew's just reached out there and said, can I pop down and have a look at how you're doing it, etc. And that's what the resources are all about as well. So you've got standard operating procedures with step-by-step guides, as well as those flow charts, and they're there to access on our website. So please, have a go, see what you might work for you as a practice, and look to implement those. We are running a follow-up session next week, just for a quick 30 minutes. It's a drop-in session. The registration is on the slides, which will go out by tomorrow from Leanne Maitland. And in that session, you'll be able to talk directly to Kay about any questions you've got as a result of the work, the presentation today. But in addition to that, we are opening up that wider programme. So we've secured some funding for phase 2 of the programme, where we will be taking a further 20 practices on that journey with us. So that covers North East and North Cumbria. So I'm sorry those practices who've joined us who might be out of area, but that we've still got access to all of those tools. Leanne has popped in that Q&A session in there, and you might want to come along and just find out a little bit more. What's in it for me? What do I have to sign up to? Is there a practice payment, etc., etc.? And we'll be able to give you all of that information during that half-hour session, so that we can kind of answer those questions. I think you've heard from both Jeannie and Chris how invaluable it's been. So we want to make sure that we get our practices signed up and take up those 20 places to enjoy that experience, to give you some thinking space, to be able to come out of practice, to work together, to do a deep dive on what are some of the challenges that you face on your own demographics in your practice, and how do you use some of those tools to make a difference. We are looking for expressions of interest for those 20 practices by the 9th of August, and that's going directly over to Anne Richardson. Anne's email address is on here, but you can also see that on that web page that Kay showed you. So it's got some information about those expressions of interest. Those people who come on that journey with us, there is a small practice payment to help you to release time to do and carry out some of that work, but you will be supported by the wider team. So it's not just myself, we've got a steering group which Mandy Mitchinson will sit on, but we've got Becky Haynes, Dr. Becky Haynes from Glen Park, who looks and clinically validates the kind of pathways. You've got Chris Drummond from a practice champion perspective. He's going to support those next 20 practices on that journey as well, in addition to myself, Kay, Anne and Leanne. So you've got access to a really great expertise in a team that sits behind that. So please do consider the expressions of interest, get those in and be part of that next 20. What we'd like to see from those 8 or 9 pathways is that we get to 20 or 30 or 40 pathways, again, as a resource that other practices can use. So I've already touched on the external support, so it's just to mention that that's what you get as part of that package. In addition to that, you probably have heard about the Digital Champions programme that we've been running for the last 2.5 years. The Digital Champions, you send your expressions of interest to Leanne, and that again is linked back on our webpage for Digital Champions. And that's an opportunity really, it's a bursary, so people who attend, we obviously allocate some funding for them to be able to go through that programme. We're looking at a minimum of 12 hours of commitment over a 12-month period. Redmore Health deliver our programme with that, with some support from the rest of the team. But that's a really great opportunity to do that action, learn and set, to share best practice, to look at remote monitoring as a prime example of that as well. So that's a really great opportunity. We will have 2 cohorts which will run in November and January for those sessions, and there will be 30 places available for those 2 sessions, 15 in each. So don't miss out on that opportunity to sign up for that. And finally, on the last element for me, I think there's another slide here, is the CDRC masterclass. Everybody's probably thinking, what on earth, CDRC? Well, that is a clinical digital resource collaborative, and it's basically a patient-centric clinical resource developed by clinicians for clinicians. It really does help improve those searches, which can help lead to patient safety and help create efficiencies. So we are running a 1-hour masterclass with the expert Ben Moore, and we will have a practice join us to share their personal experience of that. You can sign up to that by clicking the link when the slides come through, and Anna has also popped that in the chat function for those who want to kind of sign up ASAP, and that's on the 11th of September. And again, Anna from Redmore Health will be chairing and hosting that as part of our masterclass series. We're always keen to learn and share what we do, so that's some information for you guys. So back to Kay. Thank you for that, Kay.
You're very welcome. So I think that was pretty much it from me, unless there's any further questions of what sort of Rachel said. Do I have anything in the chat, Anna?
There isn't anything in the chat, no. So I think, yeah, that brings us to the end of the session. If you do want to stay on and ask any last minute questions, we will stay on for a couple of minutes at the end. Thank you so much for joining today. It's been a really, really great session and great to hear from all the speakers. I'm just going to pop into the chat a link to our feedback form as well. We're always looking to get feedback on these masterclasses and see how they've helped you and what you've taken away from them. So that's brilliant. And we will be sharing the recording and the slides with all the links to the different sessions to book on. But yeah, feel free to leave if you don't have any more questions. We have finished a little bit early, so you've got a little bit of time back. Thank you.
Yeah. Thanks for attending, everybody. Appreciate it. Thank you.
Matthew, you've got your hand up.
Yeah, hi. Here, I'll stick my camera on now, so you can see it. I'm just curious, because I've not really been on one of these, events before, and I'm just looking really from a digital perspective of how we can move the ball forward. So this is really interesting to me. I'm also looking at obviously the kind of progression in the AI side of things with the e-consults and Anima and things like that. And I just didn't know whether you as an entity have a remit to review any of those things and pull anything positive out of, or is that not your area? And also thinking about the future benefits of things like that, and whether it can start to be a bit clever at pulling out information and automatically sending via EchoRx kind of potential templates to be completed for long-term conditions. It's something I've got a meeting that I'm doing with the GPIP side of things as well. So I'm kind of just trying to hit it from all angles, but I don't know whether that's any remit here. So apologies if it's not, but I'm just curious to know.
I've put my hand up. I'll take the answer to that one, because the girls are probably panicking, thinking, oh my goodness, how do I answer that? So yes, there is an element of our remit. Health Innovation North East North Cumbria, we kind of lead on a little bit of an AI and RPA area, and try and look. We've also got an expert reference panel from primary care, so that looks at those types of solutions that come through and whether that's applicable and can it be used within general practice. We have got some good practice examples. We did run an RPA masterclass, Matthew, so I will share the information, the video link to that, because that was a really useful session. And whilst it didn't link in with the AI at that time, it was looking at some of those automated processes that can really build some of those back office efficiencies and functions. And that was a really well attended sessions. I think AI is a one for the future. We've got some experts who sit in that space who are helping facilitate some of those thoughts and outcomes. We've got a couple of GPs who have some of that interest as well. And we've got a couple of practices who would look at to pilot things. So if you're one of the ones who wants to stick your hand up and say, if you've got anything, let us have a pilot, then that's great, because we can add you on to that list. You know, so there are lots of opportunities. It's not limited. We try our best to share up to date the gaps in the system, you know, so at the moment remote monitoring is a gap for people, so we fill with masterclasses where there are gaps that are really going to help facilitate some of those outcomes. But we're also very well linked in with our ICB colleagues. My line manager and director Dave Belshaw sits within the ICB within the digital team, so he has facilitated some of those. You know, you've got a new product, how do we test that into that environment? There's an asthma AI project that's happening in a couple of practices in Sunderland I'm aware of. So there are some things coming about, but I'm more than happy, Matthew, to have a conversation offline as well, just to kind of fill you in with some of the other gaps and just share some of that best practice from wider in the system. So hopefully that's answered your question.
Yeah, brilliant. Thank you. And sorry, can I ask another question? Or somebody else got a hand up? I'll be quiet.
Sorry, it was just me, Matthew, to come in there as well. At Redmore, we've got some free summer sessions on AI running over the next couple of months. So I've just put a link to them in the chat, but they might be quite interesting for what you're interested in, because what the next one is on boosting efficiency with RPA, and then the one after that is enhancing back office as well through AI. So there was one that was running at the same time as this session today as well. So if you are interested, I can make sure we get the recording sent out to you.
That's fantastic.
Yeah, brilliant. Thank you.
Thank you. And your follow-up question, Matthew?
Yeah, it was just, I don't really understand your, as an entity, do you feed into ICB in terms of, did you make any recommendations about certain IT that's really good? Because to be honest, there's a lot of work going on at the moment in my PCN. Well, actually, in South Tyneside, all 3 PCNs are seriously looking at Anima, and obviously we've done quite a, you know, there's quite a lot of interest in it, and then obviously it's kind of weighing it up, and I don't know. We're probably going to go to the ICB and discuss that potentially, but I suppose I don't know where you sit and whether it's going to be something that's going to be commissioned at scale across the whole patch or not.
Yeah, because I think it's a balance on innovation, isn't it? So the ICB want to look at doing things at scale, but at the same time not stifling innovation, and that's where you need pilot sites, etc. So Dave's kind of overarchingly having those conversations. So working with Graham Evans, GP, Dr. Mark Dornan, who sits on that ICB. And I guess what we get in the primary care world is saturated with the amount of solutions that are there. If you go to these conferences, you get emails, you get bombarded via LinkedIn, and Mark will say, that's just too overwhelming for us. How do I know what's good and what do I not? So we're actually, in our innovation pathway, we triage those solutions come in, we diagnostic call those individuals, we understand what their offer is, what's the regulation, due diligence, financial position, all of those other things, to make sure that actually that product is a product that could be on a procurement framework within the NHS. And then we pass those back to that ICB to say, these are the ones that we have had through this month, and these are the ones we think worth exploring a little bit further. There are hundreds, you'll know that, Matthew. I get myself emails come through and you're just like, oh, it's another one of those. Oh, that's just like this, etc. So we always ask that question as well. Have you done your market research? Why is yours unique to other products that are on the market? And it's asking some of those questions. But that's the beauty of working with a health innovation network, is that we specialise in that innovation space. So we're looking for those things. We can carry out that due diligence on behalf of the ICB in that system, and it just makes everything a little bit more slicker than being overwhelmed.
Yeah,
Yeah,
thank
and then
you. That's
obviously
brilliant.
I come in and sit on the next perspective. So obviously work with health innovation on this project, but obviously similarly on sort of capacity access and recovery and that sort of perspective as well. So it's really good to have that overarching kind of element of what's available to be able to feed into practices right across the area.
Thank you.
They were great questions, Matthew, and please drop me. I'll pop my email in the chat function, and if you drop me an email, we'll just get a Teams call in so that you can catch up with myself.
All right. If nobody's got any other questions, feel free to head off. Thank you, everybody.
Thanks, everybody.
Thank you.
Thank you.
Hi, sorry, can I just catch it? I was just about to write a very long email to Anna. Just thought I might just, you're okay to spare me 5 minutes? I'm based in Sidmouth in Devon, and I'm completely new practice manager, new to the NHS, new to primary care. This is my 6th week, and I've come in, and basically the first job I'm doing is reviewing all our systems, because we're not using any of our systems properly. And before I put all the information in, I want to make sure we've got the right one, and I don't feel that they are. So I was late to this meeting because I've just come from an IT meeting within our PCN about looking at systems. I caught a lot of it, but I don't really know. I'm not really confident on what I'm doing with regards to the framework and how I move forward. So our practices are looking at Heidi at the moment. So everyone's trialing it, but I worry about data and where that's going, because it's free and you can trial it without doing anything. I need to streamline our scanning system, but I can't seem to find a scanning system that works well with System 1. It only works well with EMIS. So is it worth putting all this into an email to somebody and getting some guidance? Because we don't even have, even our finance systems aren't good. So our financial reporting, we don't have any monthly reporting or even quarterly, because we keep our income in an Excel spreadsheet and our invoicing in Xero. So every system's a bit not quite right. So what's the best way for me to go forward? Because I took in some of it, but some of it was still code to me that you're talking about. So I suppose, what's the best way to get some help, just to make sure that I'm making the right decisions and linking in with the right people with that knowledge?
Yeah, happy if you want to put everything in an email, Jessie. A lot of our staff that work for Redmore Health have actually got practice manager background and practice background, so link you up with somebody that might be able to give you some advice on stuff.
So is Redmore Health, are you a separate company that look at AI systems?
No, I mean, we do a lot of all different things. So we support frontline practice staff to use the technology that we've got in basic terms. So we do a lot of different types of projects, but it might be worth us just getting on a call with you to explain that and have a chat with somebody as well.
Mm-hmm.
Okay.
And there will be, yeah, and there will be some things that Redmore deliver which are out in the public domain, and there's no cost to that. But when you're looking for some of the other things there, it's, you know, it's kind of like commission and that, so it's bearing that in mind in terms of your budget in delivery, in terms of what is it, what are your scope and what are you trying to get out of that. What organisations, you know, there are others, but I would highly recommend Redmore, having worked with them for a lot of years, very experienced, brilliant group of staff. In addition to that, they've got that practice background, so that really adds value.
Because also I can see that Kay is for the north of England, and I'm realising I've reached out and I've got help in Yorkshire now. I've got someone in Cornwall, I've got someone in Torbay, and I've got a very lovely lady in Somerset who's piloting lots of AI systems across 10 practices. So I've got these, because we've got no practice manager network where I am. So lots of different people, but then I get stuck because they have EMIS, they have something else I don't have. And it's finding the right person that knows what I've got. So I've got System 1, and we're not going to change from that. And it's making sure that I'm not making changes that means that if further down the line, the ICB have got a plan to link us with secondary care, am I moving away from a system that actually has a longer plan to go somewhere else? So I've done lots of IT transformation projects before, but I'm not an IT person, so I've done the change side of things. And what I'm really keen to do is, we've got way too many staff and they're all paid really badly. So my long-term goal over the next 5 years is to reduce the number of staff, pay them better, and use AI and streamlining systems to actually make us just more effective. And to take more work away from the clinicians so that it comes into the admin team. That's my end goal. I've already managed to save, I've only been here a while, but we've already managed to make a couple of tweaks. But I mean, I arrived and on my first day, I got given an inch thick block of paper with all the policies in paper form for me to sign the back of them to put into a big paper. My HR file was already an inch thick with all these policies. They've never used Microsoft Forms. So we're very paper and manual process here. And yeah, it's just that it's those taking those steps forward.
Yeah, and I'm happy to give some advice and guidance as well, Jessie. And I'm looking at Curb, but you'll have your own CSU, and they are likely to be commissioned. CSU corporates,
corporate support. Yeah, so we support sort of the local ICB, but there will be a CSU linked probably to your local ICB. I mean, in regards, I heard you say about like printing and linked to System 1. We have a lot of practices on System 1, so that might be something I can do a bit of digging and see what they use. If you want to copy me into the email and see if I can come up with any suggestions from that perspective. We do have a lot of practices in the area who are using System 1 and a lot who are moving from EMIS to System 1, so it'll be something that they've come up with. But yeah, please just reach out. It's useful to just have that volume of contacts and information across the country.
And whilst it can be really overwhelming, so it might be worth getting a half hour in with Chris if he's got it free. He came from retail. He came from a totally different background into general practice, and he's probably only 2 years in, but he'll have gone through some of those pains because the NHS is complex. All the systems that you've got are complex, the processes are complex, how you set up your HR, your finance, payments, etc., your payroll. You have to be a master of everything because it's a really complex industry, so that's really hard to navigate. There are people who've done it well. There are blueprints out there, NHS blueprints, which should kind of share ways that people have done things. A lot of people have gone down a triage route and streamlined, and they've used a system like Clinic or eConsult to do that, because then you're creating those practice efficiencies in doing that. So there's lots of different ways that you can. Chris, I'm going to pull Chris in because he's still on the call, luckily.
Put his hand up. Actually, I think he's going to jump in.
What you face, firstly, good luck. It honestly, it's absolute. I came into general practice, and when I first started, I was plonked in. I came in as a receptionist. I was sick of what went on in retail with COVID, and I faced a similar challenge in a different surgery. And that you really do have to know everything: finance, HR. You've got to know that. You have to be a part clinician as well. Some of our GPs, I mean, you've heard Rachel mention Mark. Mark thinks I'm a fully qualified GP the way he talks to me, and I'm not. So one thing I would say is what you need help with is probably a little bit above me. But if you're not on Facebook, get on Facebook. There's some brilliant groups on there. I'm part of an EMIS group on there. There's 25,000 people in the group, and if I don't know the answer, somebody in there does. If I've got a question to ask, I just search for that question. It's been asked 1,000 times before, so don't feel like you're doing something for the first time. What you're doing, it's been done before. You just need to know how to do it. And if you don't know, you don't know. And once you do a bit of reading, honestly, everything I know in general practice is literally self-taught. I've never went on any courses. I've literally just come in and just got stuck in. But yeah, roll your sleeves up and enjoy the journey. It's fun. All I can say.
I must say I'm very lucky. The partners are really supportive. So
yeah,
I've just come in and said we need to completely relook at this. So with my second week here, I did a presentation and said these are all the things that I think I need to focus on. Am I on the right lines or not? And they said, well, we knew about some of them, but there's a few we didn't know we needed to focus on. And they've actually given me a green light to get on with it.
The first practice I was involved with was very paper based. The GP was a dinosaur. He didn't want any technology. It was all pen and paper. And then I've moved to the teams, and it's absolutely blew us away how forward thinking they are. How everything's digital, but it's took them a long time to get here. And now that they've got here, it's just it's really it's a pleasure to work here now. So yeah,
Okay.
it's a long
Really
journey,
kind.
but you'll get there.
I will. I'm going into another meeting shortly, but if it's okay, I've got I don't have your email address, Kay. I've got Anna and Rachel, so
I'll pop it in the
send
chat, Jess. I'll pop it in the chat, Jessie. If you've got access to the chat, I'll pop it in there. And I think Matthew from Amy's just said he's happy to support as well. So you've got support there should you need it.
That's brilliant. Thank you very much for your help. I really appreciate it.
Very welcome. Nice to meet you, Jessie.
Nice
to meet you.
Bye.
Bye.
Bye.